S. Patel, first year PG, sir, at Bangalore Medical College, Bangalore. So, today shall be presenting a case of a 18-month-old male baby named XYZ, second born to non-consanguineous parents, residing at KR Market, Bengaluru, religion being a Hindu, and the information was given by mother and it was reliable. So the baby was admitted on 12th and examined on 12th itself. The mother gave complaints of unable to gain weight since 6 months, loose stools for 4 days, vomiting for 2 days, and fever for 2 days. History of presenting illness.
Okay. Can I interrupt in between, or will?
Yes, sir. Yes.
Okay. So I think because at that time I will make it clear. Now there are 4 complaints here. Better you restrict to because all these are loose stools for 4 days and fever and vomiting for 2 days. So you could have restricted to 3. It is better to have as less number as possible. Okay. Yes. Now the second important, only an English mistake, nothing else, nothing wrong clinically. Don't use the word since. Okay. This is always you should use for 6 months, because for is a vague idea, gives you a vague idea. Since is when you are very accurate, since 3rd of July or since the age of 6 months, 5 days. So since is to be very accurate. So unable to gain weight for 6 months and loose stools for 4 days and vomiting and fever for 2 days. I think you can. Now after this, the examiner asks you, okay, this first question that may be asked to you, what is your hypothesis based on these chief complaints? He doesn't know anything about the case. Okay, like I don't know, I have read your history, so I know, but the examiner would not know anything beyond this. So, and he may ask you, what is your hypothesis, Dr. Ashray, after listening to these chief complaints? So, what can you answer that?
Yes, sir. Looking at the chief complaints, probably the child is having acute gastroenteritis, sir. So, suffering from a bout of acute gastroenteritis, and the child, since it's not gaining weight since the past 6 months, maybe there is failure to thrive as well.
Okay. So, whenever you say, I don't know whether others can contribute or others.
Yes, sir. They'll be answering in the chat section, sir.
Okay, in the chat section. Okay, yes, that means in the but not they'll not be able to. They're muted.
Yes, sir.
Okay.
So if you want, we can unmute them, sir.
No, it's okay. It's okay. Let's restrict to this only. We'll experiment sometime later. See, hypothesis means you have to give answer to so many questions. Number 1, the first is the problem is acute or chronic. So one is this child is having a chronic problem. This child is not having an acute disease. So this is a disease which is suffering, which is the child is suffering from long. And on top of that, there is an acute problem. Okay, so this is an acute and chronic illness. Number 2, the main problem is unable to gain weight. That is clear. That unable to gain weight means there is failure to thrive somehow. Okay, and there could be multiple causes of this failure to thrive. Since we have not mentioned anything in the chief complaints, it means we are not very sure, or we are not clear, or maybe there is no other complaint that points to certain underlying etiology or factor that can point to an inability to gain weight. Okay, so this inability to gain weight, there is failure to thrive. Now, failure to thrive could be because of nutritional reasons, because we have not taken the nutritional history so far. Yes. There may be that the child is getting less calories, or the child is spending more calories. Simple. Okay. The child will be getting less calorie because the child is having malnutrition. The quality or a quantity of food may be deficient. 1. Okay. And if there is excess calorie spending, maybe the child is having some systemic disorder. Like the child is having fever also, or maybe the child is having some congenital heart disease, due to which the basic metabolic rate is increased. So the child is spending more energy. The child may be having a congenital, maybe say a chronic renal problem. The child may be having some endocrinological problem, such as diabetes insipidus, that may present with inability to gain weight. And initially that may be the only complaint. The child may be having some some form of malabsorption, due to which so these are all the things you should state in your hypothesis upfront. And then the child is having an acute problem now for last 2 to 4 days. The child is having a bout of acute diarrhea, vomiting and fever, maybe an infective diarrhea for last 2 to 4 days. It is difficult to say this is infection. This is appears to be infective diarrhea because it is of acute duration. But it is difficult to say whether this is bacterial, viral, protozoal. That will come later on. It could be any of these things. We'll come to that later. Is that clear?
Yes, sir.
Yes. So we can move ahead.
So, history of presenting illness.
Yeah.
Child was apparently normal 6 months back, after which the mother noticed that the child was unable to gain weight and appear weaker as compared to his sibling. Mother also tells that the weight of the child at 9 months was 7 kgs and at 16 months was 7.5 kgs when the child was taken for immunization. The mother complains that he had sudden...
Now let's take complaint one by one, history of presenting illness one by one. Okay. Now here, it's very clear that when the child was 9 months old, the weight was 7 kg. And at present, the weight is 7.5 kg approximately.
Yes,
Oh, so there is hardly gain. So there is a discrepancy. You said the child was apparently normal 6 months back, and now this history of weight, not gaining weight, is almost for last 9 months. So how do you explain that?
So the mother noticed, sir, through her history, mother's history, she told it was around 6 months. Then on probing into the history and looking at the immunization card, once we saw through that, we got to know that it was like this, sir.
No, did she tell you that the weight of the child was 7 kg at 9 months?
No, sir, this was on asking, sir. She noticed this, then when was doing anthropometric, got to know that this was a case of malnutrition, so went back and asked for the weight. That time, this was told by the mother, sir.
Okay. So this was only on inspection of the records that you came to know that the child was, okay, fine. So the problem, so this clarifies that the problem is not only for 6 months, but the problem is still 9 months. But when you looked at the weight records or the growth chart, that means the child was growing well till 9 months of age?
Yes, sir. The child was growing well till 9 months of age, sir. It was having like 9 kg itself, 7 kg itself is less, sir. It comes around -2 standard deviation, sir. So the weight was below as compared to the other kids. But by taking mother's history, when it was compared to its sibling, that time mother said that it appeared weaker, sir.
Excellent. So the inference is that even at 9 months, the child's weight was not up to the standard, and that indicated that the insult, whatever insult it was, whether it was a nutritional insult or whether it was because of a disease, had started much before 9 months of age only, because the child by that time also had already gone into a moderate kind of malnutrition.
Yes, sir.
Okay. Next.
Can I continue?
Yeah, please proceed.
Yes, sir. The mother complains that he had sudden onset of loose stools since 4 days, 6 to 8 episodes per day, clear watery stools, large quantity, no blood and mucus in stools. The child is irritable and cries frequently, drinks water, on giving water, drinks it eagerly. There is reduced urine output to 4 times a day as compared to 8 to 10 times a day before, and there is decreased appetite as well. Associated with vomiting 2 to 3 episodes per day since 2 days, containing food particles. It's non-projectile, non-bilious, and non-bloodstreams.
Okay, so what is your inference on that history of presenting illness?
So by this, we can tell that the child is having a chronic problem. Along with that, on top of it, now it's an acute infection, probably viral in origin and affecting the small bowel. So,
how can you say it is viral in origin?
Sir, usually at this age group, in Indian scenario, most common is viral, sir. Most commonly rotavirus, and it's associated with vomiting also, and it's affecting predominantly small bowel, and there is no blood and mucus in stool, sir. So ruling out recently.
You said large quantity watery stool. Why can't it be cholera? Why can't it be a cryptosporidium infection? They can present with large watery stools only. So it is not correct to say, especially remember one thing, viral diarrhea or rotavirus is the most common cause of infective diarrhea in infants or toddlers in normally nourished children. When you come to malnourished children, in malnourished children, it is not the rotavirus which is the most common cause, because malnourished children are at a disadvantage. They are already immunocompromised, so they are more likely to be affected by a bacterial infection. And even salmonella, even shigella, cryptosporidium, cholera, they all can present this way. So it is not fair to say that don't commit to viral diarrhea. You cannot commit. You just say this is an infective diarrhea. This could be viral. This could be bacterial. This could be protozoal. There are more chances of bacterial and protozoal because the child is having underlying malnutrition. So I will not buy your first diagnosis of viral diarrhea. Okay, that will go at the back stage, and always the infections come, the bacterial and other opportunistic infections come first, then viral diarrhea. Okay, can go to the next slide.
The mother complains that he had sudden onset, intermittent, moderate grade fever since 2 days, relieved on taking over-the-counter medication for some time, details of which were unknown, not associated with night sweats, no evening rise of temperature was noted, no rashes, no cough or running nose, and no cry during micturition was noticed. The mother has noticed that there is decreased physical activity in the child, doesn't show interest in playing with toys, food intake is less as compared to sibling when he was of the same age. No complaints of unconsciousness, lethargy or seizures in the past 4 days. The mother also complains of recurrent oral ulcers, certain hair changes, no history of bony deformity, frequent falls during night, gum bleeding, hemorrhagic manifestations, skin changes, seizures.
The first part is okay. The fever is good. This is a well-taken history. You have ruled out, but there was no. I don't know why have you asked for night sweats in an acute fever.
So considering tuberculosis.
So that for that you need to have a long-term fever, isn't it? If you think of tuberculosis or if you think of some malignancy where night sweats are present, so the fever should be. So this night sweats appears out of place here. Night sweats and evening rise of temperature both appear out of place. They should not be here in acute fever. Rashes are okay. Cough and running nose, you are trying to rule out acute respiratory infection. Crying during micturition, you are trying to rule out a urinary tract infection. Unconsciousness, lethargy, seizures, you're trying to rule out a CNS infection. So these are perfectly fine. I have a query. You said mother has noticed decreased physical activity, doesn't show interest in playing with toys. For how long? This is acute or this is again for
this is chronic, sir. This is from the past 6 months as compared to the sibling. The mother has been noticing this.
This is an important complaint, Ashray.
Yes.
This is now, because from this history it appears that this complaint is only for last 2 days. Okay, because you have clubbed it with these 2 days acute complaints. Chronic you have already described. Yes. It is appearing, and then this complaint should have appeared in your chief complaints. I would write this definitely in your chief complaint, that inability to gain weight and maybe apathy and lethargy and decreased food intake for last 6 months. So that probably I would modify my chief complaint so that the first chief complaint would become that inability to weight gain, lethargy, and decreased food intake. So this becomes very clear that why this weight gain is less, food intake is less, and the child has some. That means the child has some psychomotor issues as well.
Yes.
At that. Okay. So this is a. I hope you get my point.
Yes, yes, understood, sir.
if you have any query or if you disagree, please state in between so that I can explain again.
No, sir. No query, sir.
Okay, next. Anybody, if he has any query, he can write in the chat box. So I'll try to answer. I can see the queries in the chat box. So far, there is none. And there are 63 participants. So if you have any query, you can please keep on writing them. And I will try to answer whenever the chance is there in between the discussion or maybe after the discussion. But you keep on writing any question that is coming to your mind at any point of time. Ashray, please go ahead.
Yes. Past history, no history of tuberculosis or measles. The child had similar episode of loose stools 2 months back, for which she took the child to a private clinician. ORS was taken and resolved in 4 days, and there is no history of any other hospital admission.
Ashray, this loose stools 2 months back, is there any other history of any other infection in last 6 months?
No, sir. The mother noticed this 2 months back. So similar episode was present, sir.
Do you think this loose motion which occurred 2 months back is a part of present illness or this is a past illness? Your illness started 6 months back according to the history. And
Yes,
now
sir.
you're saying that in past history, the child has loose stools 2 months back.
Okay, sir. It should have been included along with the loose stools history.
Absolutely. When you say the first complaint I modified, the second complaint should have been 2 episodes of diarrhea in last 2 months. The first was 2 months back, and the second is for last 4 days.
Yes, sir.
You get my point. So
Yes,
now
sir.
it becomes clear that you have a child who was eating. This modifies your hypothesis. Clearly now upfront, you are stating that I have a child who has not been eating well since 6 months for last 6 months. The child is not eating well. The child is not gaining weight. The child appears lethargic. The child is not interacting with his peers. On top of that, for last 2 months, the child started having diarrhea. First episode occurred 2 months back. It got recovered in 4 days. And the second episode is now occurring for last 4 days. So this clearly it tells you that there are 2 major issues. One is the chronic issue of not eating and not gaining weight. And the second is also a semi-acute issue of repeated, though 2 episodes, you can't say repeated or recurrent diarrhea. Okay, but you have to mention this within the framework of the present history. It won't
Yes.
go into the past history.
Past history.
Yeah, next slide.
Treatment history, the child was given over-the-counter medication for fever and ORS for loose stools.
Next.
So can I continue?
Yeah, please.
This antenatal history, the child is of second born out of non-consanguineous marriage with a gap of 1 year between the first and the second child. The mother is a registered case and antenatal history is as follows. So could I summarize the antenatal history or?
I think this is okay. We have been able to read. I think everybody has read. You can go ahead. So what is the main thing here in antenatal history that is of importance in context of present case?
Sir, one is infection to the mother, any infection, to drug intake.
Any positive history. There was nothing was there.
There was nothing positive, sir.
There is one thing which is very much positive and very important, which you should be telling.
Gap, sir. Gap between only 1 year gap between the first
Yeah.
and second.
So there is not adequate gap between the 2 pregnancies. Maybe the mother was still lactating when she got pregnant, and the second child was born before she could take good care of even the first child. So that is an important contributing factor which could have contributed to malnutrition in this child. Next. Yeah, please go ahead.
So birth history, the baby was born at Vanivilas Hospital through full-term normal vaginal delivery at 39 weeks of gestation and baby cried immediately after birth. Breastfeeding was started immediately within 30 minutes after delivery. Breastfeeding was done adequately on demand at day and night, and no feeding problems was noticed. There was no respiratory difficulty, jaundice, cyanosis, or seizures at the time of birth.
Yeah. So this is good that you have taken this birth weight. Birth weight was very important. This means that the child was born normally. The child had a normal birth weight, but if the child had low birth weight, okay, there could be another situation where the child could have weighed 2 kg, let's say. In that case, it would be important that you also take the anthropometry of the mother.
Okay, sir.
Okay, don't forget that. Whenever you get a malnourished child and the child was born low birth weight, always take the weight and height of the mother and calculate the BMI of the mother.
Okay,
Because
sir.
that is the main starting point of malnutrition. The child is born IUGR because of antenatal malnutrition, and then this IUGR doesn't get catch up because of certain problem or insult that is recurring even after birth. So it is good that you said. So we know that the child was not insulted at birth. The birth weight was okay. Breastfeeding was started immediately, and so there was no problem as long as breastfeeding was continued. I think we'll come to know more about it in your dietary history. Next.
Yes. Next, coming to the developmental history.
Is that all in the present history of present illness?
Yes, sir.
Can we go back?
Yes, sir.
Now you say no respiratory difficulty, jaundice, cyanosis, or seizures.
Yes.
Does that rule out all of your negative history? I don't get much of negative history here. We are straight away now coming to developmental history, but where is the negative history? You understand what negative history I'm asking for? Because in the hypothesis, we have hypothesized that this could be because of a systemic problem also. So all those systemic problems which could have led to this FTT need to be asked for. You need to ask for a history of increased water intake in the child. Because you want to rule out diabetes insipidus, that can present as failure to thrive. You need to ask about history of polyuria. You need to ask about any other urinary problem, like it's a male child, any dribbling of urine, because the child may be having some posterior urethral valve. Subsequent to that, the child may develop hydronephrosis, chronic kidney insult, whatever. And you may have to ask whether there was history of any. You've asked just cyanosis, but I will be also interested in if there was any suck cycle, any feeding difficulties, okay, to rule out any sweating over the forehead, to rule out any congenital heart disease. Okay, yes. I'll also be interested in metabolic diseases, congenital diseases, heart disease, and what else? The renal we have talked about.
Malabsorption.
Malabsorption, yes. So about the stools, you should have commented. That was very important. I don't see any comment on the type of stools, whether they were large, bulky stools, how many times the child used to pass, maybe the child is having, you are having a child with celiac disease. Who knows?
Yes, sir.
Maybe it has got to know. So you need to ask when the gluten containing foods were introduced and whether it had any relation with the stool pattern or the weight loss or weight gain. So all that is not there in your present history. Also in the present history, there are other things which are lacking is history of night blindness. You have said that the child does not fall at night. So this only tells you about bony pains also, you had said somewhere.
Yes.
Yeah. Frequent falls. So you have taken care of vitamin A, you have taken care of C, and you have taken care of hypocalcemic seizures, maybe. Okay, so seizures. So this is all. You should also be asking about one major thing that you should be asking about, whether there is any history of progressive pallor.
Okay, sir.
Because I don't know whether further in your history examination pallor is there or not, but you definitely need to ask whether there is any history of progressive pallor. Rather than asking about hair changes, they are very non-specific.
Okay,
Mother may not notice. So this is a superfluous asking about hair changes. And yes, oral ulcer you can ask about, but I will be more interested in asking about the. So all these negative history is lacking, which need to be there. I hope you get my point.
Yes, sir.
The second negative history, more importantly now, is what you need to tell that is lacking. Again, in a child with malnutrition, we not only need to know what the child is eating, that you will tell us in the dietary history, but how the child is eating is very much important. How the child is eating means you will have to tell the child was being given, or you will be telling all that in the dietary history?
Yes, sir.
Okay,
The dietary.
for the dietary history then.
Yes,
okay, then let's move ahead. So negative history is lacking. The negative history should be there about acute problems, which you have already told, like seizures. Seizures can be because of hypoglycemia, hypocalcemia, hypomagnesemia, hyponatremia, hypernatremia. All these things you have ruled out by taking the history of seizures. So it not only rules out your CNS problem, but also rule out a lot of metabolic issues.
yes, sir.
Okay, we go to the next slide.
Sir, this about the chronic problem of the child, about the severe respiratory, this thing, we should mention it at the end of HOPI or in the postnatal history at the end?
At the end of HOPI. At the end of HOPI, all these negative histories need to be mentioned.
Okay, sir. So, developmental history, gross motor, the baby is able to walk without support, and it attained this at 17 months. Fine motor, spontaneous scribbling was present in the baby, attained at 16 months. Adaptive and social skills, it turns pages of around 2 to 3 pages at a time and uses spoon but spills the food, and both were attained at 17 months. Language, speaks 2 to 3 words with meaning and follows one-step command, attained at 16 months.
So what is your impression on this development? Is it normal or is there a delay?
Yes, sir, it is normal, sir. It looks normal in this child because the sibling also attained at the same age on asking. So
I won't say that this is normal. This is an 18-month-old child. I'll say that your history is inadequate. I don't have enough information to say whether it is normal or not. You say the child walks without support. Okay, that means the child could be anywhere between 13 to 15 months. But what about after that? So you've also written expected age 15 months. That is the maximum upper limit. But
yes,
what all you expect the child to do at 18 months in gross motor, we have not asked. Simply spontaneous scribbling would again come at 15 months. Adaptive social uses spoon with spilling. Spoon with spilling would be around 15 months, 17 months, which is late. Even by this standard, you take the I'm just highlighting. These are all the, isn't it? Or is it the median?
sir, we couldn't hear you, sir.
This expected age that you have written is the upper limit of expected age. Or is it the
Median, sir. Median.
okay?
It is the median, sir.
Let's say we move ahead. So this appears more or less gross motor area, but there is no cognitive dysfunction. Okay. Next slide.
Immunization history, the child is immunized up to date according to national immunization schedule.
Okay, we have 3-4 questions in the chat box. Ashray, I'll take the question. One is the first meant given the first and second child was less than what we expect. The second is, sir, we cannot rule out diarrhea due to cholera based on history, as a patient would not present with history of fever, and also child would have gone to shock based on the quantity and presented. Cannot be ruled out diarrhea. No, you cannot rule out diarrhea due to cholera because every patient of cholera does not go into shock, and the cholera can also cannot
Excuse me, sir. Sorry to
the third
interrupt.
question.
Sir, the voice is breaking, sir. We are not able to hear you.
Hello.
Hello?
Hello.
Yes, sir. Now it's audible, sir.
Yeah. Okay. I think I have lost all the questions because of this interruption. So we can go ahead and we'll take more questions when they come. There are no question in my chat box as of now. Please.
Coming to the dietary history,
Ashray, go ahead.
the child was exclusively breastfed till 4 months of age, following which she started on cow's milk in 1:2 dilution, 400 ml per day. She has been breastfeeding twice a day since then. Complementary feeds were started at 9 months of age. The child was mashed rice with dal twice a day. Now, the present dietary history by 24-hour recall method was taken. So the total calories was 498 kilocalories per day and protein intake was 13.8 grams per day, but the expected calorie intake should have been 1060 kilocalories per day and protein intake 16.7 grams per day. So there is a gap of 53% deficit when it comes to the calories and 17% deficit when it comes to the protein.
So what are the problems in feeding or dietary history of this child? Number from 1, 2, 3, 4, 5. Start from the beginning.
Sir, initially the child should have been exclusively breastfed till 6 months of age, and that was
okay.
not done.
So the child was not exclusively breastfed for 6 months. Number one problem. Number two.
They started on cow's milk, sir, which shouldn't in 1:2 dilution, and the requirement also was less, was around 400 ml per day, and she has been breastfed only twice a day since then. And then they've started complementary feeds also late, sir. At around 9 months of age, they've started complementary feeds, and the amount that is given is also less, twice a day. And in the complementary feeds also, they've
Any
not.
other point?
And in the complementary feeds, they've not included all the food sources which they were supposed to include, sir. Like all the 5 components weren't included in the complementary feeds once they gave.
What are the 5 components?
So one is cereals they should add along with vegetables and fruits. Then legumes, pulses or nuts can be added. Then milk and milk products or meat or egg products and fats and sugars, sir.
Okay, so I'll add. You have been able to point out most of the things, but I'll just add. Number 1, the child was not exclusively breastfed for 6 months of age. Number 2, the complementary feeding was started late by 9 months of age. Number 3, the complementary feeding was neither adequate nor it was. We don't know what was the consistency because you haven't asked that history. It is important to know what was the consistency of complementary feeds and how frequently the child was being fed. Now, from your 24-hour recall, it is 5 times a day for 18-month-old child. But we don't know at that time what was the child being fed. And you are absolutely right that all the 5 groups are not being given. From this diet, there is gross calorie deficiency, there is protein deficiency, and we can also see that the foods rich in iron, and that should also be one line that you should be adding, because I don't see any iron food except for what all little bit of iron may be there in the in dal and all, but not much iron or micro. There are no fruit or vegetables which are included except for maybe some vegetable if they were putting in sambar, but that would not be enough. So we expect a child who will be having gross chronic malnutrition if the child is consuming this diet. What we expect in our anthropometry, At this point of time, you should be expecting what you are going to get in anthropometry or examination. What I'm anticipating is that the child will be having gross underweight. The child may also be having stunting, should also having stunting because it's a chronic insult. The child should also be having wasting because there is an acute episode of diarrhea coupled on a chronic weight loss. Number 3. Number 4, the child, I also expect that the child should be having moderate, at least moderate pallor, because there is hardly any iron containing foods. And I am also expecting that the child will be having some other features of micronutrient deficiencies, because there is hardly any fruit and vegetable. So these are 5 things which I should see in your history examination and your interpretation. Okay. And if I don't get, that means either something is wrong in the dietary history or we may have missed something in our examination. Please go ahead.
Yes, sir. So coming to the family history, it's a extended family. There are 6 members in the family, including the grandparents, parents, and 2 kids. Sibling is of 3 years old boy child. No abortions or stillbirth were present, and there was no history of tuberculosis contact, early death due to any congenital or chromosomal disorders in the family.
Yeah, please. Next.
Pedigree chart. Then the socioeconomic status.
Okay.
They stay in a Paka house which has 2 rooms, a kitchen, a separate bathroom and toilet facility with adequate sanitary measures and clean water supply by the corporation water which they drink and use. Hand hygiene is poor, and the mother, even on asking, the mother is not aware of hand hygiene. Father's occupation, his father works as a laborer, education till middle school and earns around 5,000 per month. Mother is a servant by occupation, earns around 5,000 per month, and she did not go for any schooling. So on doing Kupuswamy scale, they come under class 5.
Okay, next. So it is from a lower socioeconomic group they are belonging to. Next slide.
So summarizing, 18-month-old child of birth order 2, born of non-consanguineous marriage, full-term normal vaginal delivery, belonging to class 4 Kupuswamy scale, all developmental domains achieved and fully immunized, was brought to the OPD with history of unable to gain weight since 6 months, loose stools since 4 days, vomiting and fever since 2 days, dietary deficit of 98 kilocalories and 2.9 grams per day of protein. With this, would like to consider child is suffering from acute infective gastroenteritis with some dehydration and protein energy malnutrition.
I like to, the first part is okay, your summary is okay, well written. But the second part I like to differ, because here what's your major issue is, the first thing that you state that acute problem is more important, while I feel that the chronic problem, that is the undernutrition, is more important. So to give more weightage to that, I'll say that this child, I like to put it this way, the summary of history, that this child is suffering from failure to thrive, and with the calorie deficit. This appears to be because of chronic nutritional insult. In addition, I will like to examine the child to rule out any systemic disorder. The child is also having an episode of diarrhea as of now, which appears infective in origin. Considering the malnourished or the nutritional status of the child, this diarrhea is more likely to be bacterial or protozoal in origin, and though it could be a viral origin also cannot be ruled out. So I like to examine all these things. So this is how I will like to put the second part.
Yes, sir.
Next.
General examination, the child was seated on mother's lap during examination. Child is irritable, not interested in the surroundings, and gross wasting is present. Vitals, temperature 98.6 degrees Fahrenheit. Pulse rate is 150 beats per minute. Respiratory rate 26 cycles per minute. Capillary filling time is less than 3 seconds. On looking for hydration status of the child was irritable, dry oral mucosa and tongue was present, skin pinch test, it goes back slowly, drinks water eagerly, and there is reduced urine output.
Important things here are, the firstly, which is most important, is that Ashray has done it right. He has written the exact temperature. That is very important. Most of the time, what students do, they would write temperature, patient is afebrile. Okay, that is not correct. In a malnourished child, we are more interested in hypothermia than fever. So we need to know the exact temperature. So always measure the exact temperature in a child who is malnourished. And hydration, what is your impression on hydration, Ashray?
So there is some dehydration present in this child, sir. Look, going by the history.
How can you say that?
So on looking at the general condition, the child is irritable. There is dry oral mucosa and tongue. Skin pinch test is prolonged, and the child drinks water eagerly, sir. By these points, would like to consider some dehydration.
Yeah, but in a malnourished child, you see the child is irritable otherwise also.
Yes,
for
sir.
last 6 months, you are saying the child is irritable. Yes, dry oral mucosa and tongue also don't carry much value here. And you have not examined. Acha, this is on examination. Skin pinch, again, the skin pinch goes back slowly, again can be there in a malnourished child without dehydration. So these are the two most important things, are two last points, that the child is drinking water eagerly and the urine output is reduced. I'll go by that the child is having some dehydration. Shravan has written depressed anterior fontanelle. Shravan, depressed anterior fontanelle is also common in malnutrition per se. So it is not a feature of dehydration in severe malnutrition. Next.
Examination, pallor was present, but on examining the palmar crease, there was the color was the same. Then icterus was not present.
So what do you say? Pallor is, there is what is some pallor, moderate pallor or severe pallor?
The moderate pallor, sir.
Moderate pallor is there. Okay.
Icterus,
the rest is not there. Icterus, cyanosis, clubbing, lymphadenopathy, edema, pedal edema up to 1.
Ankles are present, sir.
Why do you have to write up to ankles?
Sir, we can grade the edema by looking up to where.
Do you ever write pedal edema up to knees, or pedal edema up to hips, or no, pedal edema up to umbilicus? You don't write that.
Yes, okay. Pedal edema is up to
you just say pedal edema. Pedal edema is fine. When you say pedal edema, it implies that you have seen it on the tibia and on the ankle only, and this is good. Okay, you can say there is no generalized, there is no anasarca, but there is only pedal edema is present. Yeah, next.
So head appears normal in size and shape. Sunken antefontanelle is present. Hair is lusterless, thin and brittle. Face, there is hollow cheek appearance and no frontal bossing was noticed. Oral cavity, oral mucosa is dry. Ulcers present. Fissures present at the angle of mouth and lips. No cleft lip, palate or gum bleeds was noticed. Eyes, no white spots, ulcers, scar, corneal neovascularization, conjunctivitis or conjunctival hemorrhages. Ears, no discharge was present. Nose and oral nasal cavity examination was normal. Neck, no rashes on the neck was noticed.
I hope everybody is clear why he has asked so many things. And here, you know, face, hollow cheek appearance. Can we go back? Hollow cheek appearance. Now, what does that mean? That means this child has lost subcutaneous fat in the cheek also. So that is suggestive of very severe malnutrition, a buccal pad of fat. When you say hollow cheek appearance, that means the buccal pad of fat is lost. Ulcers are present, fissure present, that points to vitamin B deficiency. There are no gum bleeds, no bitter spots, rules out vitamin A deficiency. Corneal neovascularization, especially riboflavin and thiamine deficiencies is ruled out, and conjunctival hemorrhages, C deficiency is ruled out. No rashes around the neck rules out pellagra. Okay, next.
Yes. Chest ribs are prominent. There is no rachitic rosary or Harrison sulcus.
Yeah, you don't need to read. You don't need to. I let everybody read. I'll just explain. Ribs. So there are no signs of vitamin D deficiency on chest examination. Umbilicus is inverted. Abdomen is protrudent. A protuberant abdomen is usually because of hypotonia. This hypotonia can be secondary to only protein energy malnutrition or can also be a sign of rickets. So protuberant, it is not protrudent, it is a protuberant belly or a protuberant abdomen. Visible wasting, no perianal excoriation. Perianal excoriation, if it was there, it could point to three things. Number one, it could be a pericandidiasis. Number two, it could be a acrodermatitis anthropathica. And number three, it could be some contact dermatitis kind of rash. So if there is a or it could be I have left one thing, Ashray. What more? Perianal excoriation. I have given three causes.
So zinc deficiency was
Zinc I have stated.
Anthropometric.
Anybody else? Not pinworm. Lactose intolerance is correct. Hirsch said lactose intolerance. That is absolutely correct. Not the cow milk. Primarily lactose intolerance we will be looking for when we are talking perianal excoriation. Then you have knuckle hyperpigmentation that points to B12 deficiency, and then skin is shiny. Actually, all these things, when you are saying this, all this should come in your general physical examination when you are describing the child. I'm like you said, the child is wasted. I would have said like that, so that a picture evolves in front of my eyes. I am not seeing the child, but had you said, sir, I am describing a child who appears grossly wasted, the child does not appear interested in surrounding, the child has a very hollow cheek, the child has a hollow cheek appearance, the child is having loose folds of skin hanging around the thighs, around the groin, and the child appears, the ankle appears swollen, there appears to be some edema. Can you go ahead?
So
go ahead on the slides. Yeah. So, and this child is having the scapulae are prominent, the abdomen is protuberant, and there is knuckle hyperpigmentation. However, the child does not have any rash or the child does not have any visible wasting. The hair are lusterless and thin. So this is the whole picture which you should be telling in first. That is the first impression. You don't break it into abdomen, genitalia, groin, back, extremity, like head to toe examination. Don't break it like that. You give a general picture that paints a photograph of the child in front of the eyes of the examiner. I have 5 questions here. I'll take that. I think we have talked about them. Depressed interfontanelle, pinworm, lactose intolerance, common. Okay. Ashray, please go ahead.
Anthropometry, weight for height was below -3 standard deviation. Weight for age was below -3 standard deviation. Length for age was -2 to -3 standard deviation, and weight for length was below -3 standard deviation. So on doing mid upper arm circumference, it was 10 centimeter. Inference was severe malnutrition. Head circumference was within the median range. So by this, my inference would be there is severely underweight, stunting, and wasting present in the child.
Classify the stunting also. Like you said, severely underweight is severely underweight.
Yes.
Moderate
stunting will be the
moderate stunting. Severe stunting will be
less than -3 standard.
Below -3 SD. And what about wasting?
Wasting is severe wasting, sir.
Severe wasting. Mid upper arm circumference 10 centimeters. That means
severe malnutrition is present.
Severe malnutrition. Excellent. So now I'll ask you 2-3 questions. Which
Yes.
charts you have used to see the expected outcome?
So I use WHO chart, sir.
You use the WHO charts.
Yes, sir. So in the WHO tables which have come, sir, WHO chart provided the percentile, sir, then referred to the table which gave in terms of standard deviation.
Ashray, have you ever seen? I ask these questions, please remember them. So we have answers to them when anybody asks them. Ashray, so I'm just giving an example of Viva Voce at the exam. Ashray, have you ever seen WHO charts?
Yes, sir.
Yes, sir. Okay. In which color are WHO charts printed?
Sir, pink for girls and blue for boys, sir.
Great, very good. How many lines are there in a WHO chart? How many curves are there in WHO chart?
Sir,
In a
5
typical-
curves, sir.
5
6
curves.
sir.
Huh?
6,
How
sir.
many?
6. Sir, 3rd percentile, 15th percentile, 50th percentile, 75th percentile, sorry, 85th percentile, and 97th percentile, sir. 5, sir.
Can you repeat?
3rd percentile.
You have you have 5 curves. You are absolutely right.
Yes.
The middle one is the 50th percentile or median. Okay.
Yes,
then there are 2 above that and 2 below that. So what are the ones above?
sir, above is the 97th percentile and the 85th percentile, 15th percentile, and the 3rd percentile, sir.
Absolutely correct. Very right. Very right. Can you tell me why 85th percentile? What is the significance of this curve of 85th percentile and 97th percentile? Or on the other side, 15th percentile and 3rd percentile?
Sir, it will match with +1 standard deviation and +2 standard deviation, -1 standard deviation, and -2 standard deviation. Sir.
Very good. Excellent. Very good. Very good. I rarely get that answer from a first year postgraduate, Ashray. So I think that is very commendable. So it is. So please remember the 15th percentile is for -1 standard deviation. 85th percentile is for +1 standard deviation, or standard means Z score. They are same for all practical purpose. And the 97th percentile is +2 Z score, and 3rd percentile is -2 Z score. So this child is having severe underweight, this child is having moderate stunting, this child is having severe wasting and severe malnutrition according to mid upper arm circumference. Now you see, all these things we had already predicted when we were analyzing our dietary history. So when you are presenting a case of SAM, severe acute malnutrition, take care that your dietary history and your anthropometry are cohesive. They point to each other. Because if you are getting now only acute malnutrition, no stunting, I will not believe your dietary history. Okay, simply I'll say that there is something wrong. Either your measurements are wrong or your dietary history is wrong. Both have to go in hand. Good. So we can move ahead. Now you have to be very clear on measuring, how to do the measurements. Obviously, in this class, we cannot teach you or cannot demonstrate how to do all this. But please take care, take help of your seniors, take help of your faculty to see how exact measurements need to be done in the examination.
Sure,
Next.
sir.
Yeah.
Systemic examination. On doing gastrointestinal system examination, inspection, there was protuberant.
Ashray, you have done GI examination, then you have done CNS examination. I saw all the slides.
Yes, sir.
Okay. And these are not necessary primarily,
Okay.
because all these are normal
Yes,
in
sir.
a child with severe acute malnutrition, except that you have a palpable liver. So you have said liver span was 9 centimeters and there is no fluid was noticed. Otherwise, there is no need for detailed examination in this child.
Yes, sir.
There are 2 questions here. One is from Pa1.
Pavan, sir.
Okay, great. I thought it was another version of Pa. Pawan, how do we comment on -3 SD on growth chart, sir? Pawan, we don't have a -3 SD curve on the growth chart. You have a for -3 SD on the WHO growth chart. For -3 SD curve, you have to refer to the tables. If you see the tables in the clinical methods book, you have -3 Z score, -4 Z score also given in these tables. For better to see the tables for these -3 or, and you can actually calculate exact Z score. There is a software, it is known as the WHO Anthro software, and if you just put the age of the child, weight of the child, you will get the Z score. That the weight for age of this child Z score is -3.4. Like that, you can get the exact Z score. Anthro software. It is known as WHO Anthro software, available free of cost. The next question from Shravan is if protuberant abdomen is due to edema due to SAM or due to hypokalemia. It could be both. Edema, it could be both. It could be both. You can't differentiate. For older children, can we use WHO chart? No, for older children means up to 5 years, we use WHO charts only. This is very clear. Up to 5 years, WHO charts, and after 5 years, you use the IAP growth charts. So I think there should be no confusion in that. Yeah, thank you. We go to the Ashray, we go to you. Yeah.
Diagnosis acute infective gastroenteritis. So, sir, I should tell about malnutrition first and then go to the.
I'm happy you made that correction yourself. So the first thing that you will be talking about is severe acute malnutrition. There is no need to grade wasting and edema in the diagnosis. Please remember that. Wasting, when you say severe acute malnutrition, it implies there is severe wasting. Okay, so you don't have to grade this at all. So I will say the diagnosis, my diagnosis of this child is severe acute malnutrition with severe acute malnutrition with moderate nutritional anemia. I will not say iron deficiency. Okay, you have just seen pallor. You have not estimated iron. This pallor could be because of iron deficiency, B12 deficiency, B6 deficiency, B2 deficiency, magnesium deficiency, and what all. So this is simply labeled as nutritional anemia, and there can be multiple. Yes, iron will be one of the major factors, but you will simply here say nutritional anemia, vitamin B deficiency. Another important thing which, yeah, you have mentioned that edema. So here you can say severe edematous severe acute malnutrition. I will label this child as having, because edema is the most important. Edema means that the child is uncompensated. So an uncompensated child, the risk of mortality is more. So yes, the first diagnosis I will give this child is edematous severe acute malnutrition with moderate nutritional anemia, with multiple micronutrient and vitamin deficiency, with acute diarrhea or acute gastroenteritis with some dehydration.
Yes, sir.
Okay.
Yes, sir.
Fine. Let's go ahead. So this is okay. So this is all about the till diagnosis. I think we have reached here. So the next question, any questions at this point? Let me look at the chat box. What should we not, grades of wasting? Grades of wasting are superfluous. There are only 2 grades according to WHO, the moderate wasting or severe wasting. Moderate wasting is between -2 Z score to -3 Z score of weight for height or weight for length, and below -3 Z score is severe wasting. So just remember that. The rest are all, they are various kinds of wasting or various classifications are given, but they are just theoretical. The management will be according whether the child is having moderate wasting or severe wasting. What should we not miss in GI examination in SAM case? GI examination, primarily you have to tell about the liver, which is the most important thing, and mainly any free fluid or any other. I think there is not much in a SAM case. If it is only nutritional insult, you don't find any much findings in the gastrointestinal system, except that there is fatty liver enlargement that you should not miss out. I think that's about this thing. Okay. So how should we mention PEM and final summary, as there is protuberant belly and edema? See, this term PEM is now outdated. Remember that. The term is now severe acute malnutrition. I'll just show you. I just have this book at hand. This is a very small book on severe acute malnutrition, written by myself and Dr. Praveen Kumar. So this is a good book. If you wish, you can get it from Amazon or Flipkart. So severe acute malnutrition.
Yes, sir, the book helped me a lot, sir.
Sir, we have already mentioned this in our groups also, sir, about your more than 30 books. Maybe, sir, as separately there is pediatrics books for PGs and undergraduates. We have a textbook on pediatrics by sir, and topic wise also you have written so many books, sir. We already shared all about details in our groups so that most of our members get benefited. Thank you so much, sir, for those contributions.
So this is severe acute malnutrition. We now don't label as PEM, and severe acute malnutrition, the diagnosis is simple. The severe, and this again, you said kwashiorkor, marasmus, they are terms of the past. This is only of academic interest, and it is of interest only to a very, if there is some very aged examiner who comes to you. So all those examiners beyond 60, 65 may ask about marasmus, kwashiorkor. So you can tell edematous severe malnutrition is again kwashiorkor, wherever there is edema, otherwise it is marasmus less than 60%. The term is now severe acute malnutrition, which is defined as number 1, weight for height or weight for length minus 3Z score. I've already said that. Number 2, mid upper arm circumference less than 11.5 centimeter. And number 3, gross wasting, gross visible, severe visible wasting. That is the number 3. And number 4, edema without any other explainable cause. So either one of these is possible. Either one of these makes a child as having severe acute malnutrition. Okay. Not all need to be. Suppose a child is having weight for height Z score between -2 and -3, but the child is having edema. This child will become a child with severe acute malnutrition only because virtue of having edema. I hope I am clear. Yes. All the criteria need not be fulfilled. Okay. Now, how will you manage this case, Ashray? The next question, obviously, the examiner comes to you and asks you about. What I'll do is I'll first show you some slides. Okay. Can I share my?
Yes, sir. Yes, I'll stop sharing the screen, sir.
Yeah. Now, because somebody sent me this question, this case scenario was asked in the DNB, recent DNB examination. This was a, some student sent me this question, and the question was like this: read the following history and write the chief complaints. A 1.5-year-old unimmunized girl is brought with, you read it, and then I'll make it full screen.
A 1.5-year-old unimmunized child is brought with frequent loose stools and vomiting for 7 days and poor oral acceptance for the last 3 days. The child is predominantly milk-fed, half-diluted buffalo's milk with bottle, in addition to some biscuits. She has been having recurrent such episodes since 6 months of age. Her weight and length are 5 kg and 68 centimeters respectively.
So the question is, write the chief complaints. So anybody can anybody attempt to write what should be the ideal chief complaints? How will you frame the chief complaints of this child? Can you try, Ashray? or anybody else? I don't know whether others can speak or not. See, what is
A child
yeah.
with recurrent episodes of recurrent episodes of loose stools and vomiting since 6 months of age. We'll start with, sir.
I think that is absolutely perfect. Now you see, this is a chronic problem. So your first chief complaint, as Ashray has correctly said, will be recurrent episodes of loose motions for 1 year. Okay, I prefer not to use the term since it has different connotation. So the child is now 1.5 years and diarrhea is occurring since the age of 6 months of age. So I'll say first complaint is recurrent episodes of loose motions for 1 year. The second complaint will be loose stools and vomiting for last 7 days. And the third will be poor feeding and oral acceptance for 3 days. See, the idea is that the duration of nutritional insult or the disease should figure in the presenting complaints. So that is that means the child is having a chronic problem. The hypothesis will be the child is having a chronic problem due for last 1 year, and maybe the child is having decreased immunity because of malnutrition, because of some immune disorder, or because of some systemic illness which is causing these recurrent infections. Okay, this is also a child can present because the mother may not say at all that the child is having less weight or the less height or the less length. This was only the last point you examined, only you found on examination. But mother never said this. What she is worried about, that the child is having repeated diarrhea, repeated infection, and that's why the child is getting weak. That is her impression. So that also needs to be brought out. Enumerate points in history you would like to ask to rule out nutritional deficiencies. Ashray has already done that. So I'll just state that you have to ask about pallor, number 1. You can note it down. Now you have to ask about any swelling. You have to ask about night blindness, not growing well. Then any ulcers, whiteness or ulceration of eyes, bony pains, swelling, gum bleeding, skin bleeding, and perianal excoriation. So I'm happy that Ashray has taken all those histories to rule out any micronutrient deficiencies. The third question you can see here. Now, how will you describe this child? Suppose this child comes to you. So I'll say that the picture shows that there is a child who is conscious. The child is alert. The child is grossly wasted. There is visible severe wasting of muscles. The buccal pad of fat is, however, preserved. This child has edematous feet, as you can see, cracked skin, and eczematous skin changes are also present. There are loose folds of skin hanging around the groin. The abdomen is protuberant. The ribs are prominent. There appears, now you can see here, there appears to be a pectus excavatum, and the child is having, and you can see here in the inset that the child is having severe pallor. There are shiny skin over the leg. So this is how you have to describe the abdomen is protruding with prominent veins. So this is how you have to describe such a child so as to give a visual picture to the examiner. So can you list, Ashray, now major problems this child is having that need management? Suppose I ask you, tell me 1, 2, 3, 4 problems. So what are the problems? Yeah.
The triad is infection, hypoglycemia, hypothermia, sir.
No. This is what you are anticipating. I am asking what are the problems you see you have identified in this child till now from history and examination?
So one is treat the acute infection, then start treating for the dehydration. Then start since
you didn't get my question, Ashray. Let's say, what is the diagnosis?
So the diagnosis is severe acute malnutrition with.
Okay, so that is your first problem, severe acute malnutrition. What is the second problem?
Okay, sir. So then treat the micronutrient deficiency.
The second problem is severe anemia.
Severe anemia. Yes, sir.
The third problem is recurrent diarrhea. And the fourth problem is poor feeding. So these are the four problems this child is suffering from, and you have to investigate accordingly, and you have to treat accordingly.
Yes, sir.
This is known as a problem solving approach. You have to identify what is the problem the child is having at present. You have to tell me the time, how much time I have.
So the time is
Time is not a constant, Professor. We need to cover this topic, sir.
Okay. And then you have to write a plan. Then obviously you are asked what is the plan for management of this child. And the final question, when will you discharge this child under ideal conditions? So please read it. The management, you all know the 10 steps of management. But once the examiner asks you, how will you manage? The most common answer that starts emerging is, sir, we will look for hypoglycemia, we will look for hypothermia, we will look for dehydration. See, this all is a very theoretical answer. You have already seen the child. You know whether the child is pale or not. You know whether the child is dehydrated or not. You know whether this child is eligible for oral feeding or you need to give nasogastric feeding. So all these points you have already seen. So your management should be personalized. Like in this child, Ashray. So we'll go back to your case now. I'll stop sharing my slides and we'll go back to our discussions. Yeah. So now, can you tell me how will you manage your child, the child that you presented?
Manage the dehydration, sir, and control the infection. So initially we do a set of investigations, sir, before going to the management. In investigations, it will include as we have ruled out already in the history hypoglycemia, then we'll do a CBC and differential count, sir.
How will your CBC and differential count help me? Ashray, tell me.
Sir,
what is your problem? Your problem is severe acute malnutrition. Your problem is anemia. Your problem is watery diarrhea. Okay. And your problem is micronutrient deficiency. These are your problems. Okay. In severe, so is there any acute, what you need to see immediately? The first thing, your temperature is okay. You have already seen the child. So you'll say, how will you begin the child? How will you will say that the child is maintaining temperature. It is good. And I will emphasize on the parents or the mother to maintain this temperature. I will also teach her kangaroo mother care. If needed, she can give that to the child and keep the child warm. I will praise her for keeping the child warm, as the child is warm as of now also. I'll also teach her how to detect hypothermia by touch technique. That is number one. That will be my first thing. Number two, sir, I'll also like to do some investigations. Firstly, I like to do a blood sugar, because if it has already been done, I don't know. Though the child does not appear to be hypoglycemic, but he can be asymptomatic hypoglycemic. I like to do a blood sugar, and I will like to do a hemoglobin estimation.
Yes, sir.
Yeah, CBC may not give you much clue. What you need to do is a hemoglobin, and you will say, sir, if a hemoglobin is less than 4, I will give a transfusion packed cell. If it is more than 4, I will not do anything at this stage. Control the infections. We can start the iron after 1 week of starting of therapy. Okay, that is number 2. You will take care of this. And then you have severe acute malnutrition. Then you say, sir, the child is not in shock. Okay, the child is having some dehydration only. So how will you treat this dehydration? Now you have to tell me. The third thing is, now you have to treat this dehydration.
Yes, sir. For treating dehydration, we can use ORS, sir, in half dilution, sir. 1 ORS in 2 liters bottle we can use. And that we give over every 30 minutes for the initial 2 hours, and then alternate hours alternate hours up to 10 hours, sir, along with F75 food, sir.
So you will see that we will start, F75. I will straight away put this, I will not give IV fluids to this child. That is very important.
Yes.
Why you should not give intravenous fluid in a child with severe acute malnutrition? There are 19 questions in the chat box. I'll come to them. But this is important. Please listen to this carefully, what I am talking about. Do not advise intravenous fluid in a child with severe acute malnutrition. This can kill the child. A child with severe acute malnutrition, though he looks wasted, वो कहते हैं ना सूखा हुआ बच्चा है.
Yes.
Even if the child is non-edematous, the total body water in the child is higher.
True, sir.
The total body sodium in the child is higher. Potassium is lower. So any fluid given unnecessarily can cause fluid overload, congestive heart failure, and death. That's why IV fluid is indicated only when the child is having severe dehydration or shock. And there also, how do you treat? Usually dehydration is treated by giving 30 ml per kg of ringer lactate or normal saline in
severe dehydration.
Severe dehydration कितना देर में देते? In 30 minutes. ना initial fluid is 30 ml per kg of ringer lactate, or you give in first 30 minutes. In severe acute malnutrition child, you half the fluid and you double the time. So you in a shock, in a severe malnutrition child with shock, you give 15 ml per kg in 1 hour to treat shock. Remember this. Okay, 15, and don't use normal saline or ringer, preferably you use N/2. So that also to give less sodium to the child.
Yes,
so
sir.
this is very important, that sodium, even if the child sodium, serum sodium is low, that does not reflect the total body sodium. So don't treat hyponatremia in a child with severe acute malnutrition by pumping sodium, unless the child is having a hyponatremic seizure. ठीक है, तब बात हो रहा है, but otherwise don't. So is this clear?
Yes, sir.
Don't give intravenous fluid until and unless indicated in this child. I'll just take Ashray these questions. There are several questions. I'll just go from the very beginning.
So only one, so mostly. Why is iron supplements contraindicated in acute infections? They've asked.
Can you answer that?
Yes, sir. Because of free radical injuries, sir. And as it is, there'll be more of free radicals, and on giving iron, there can be more of free radicals, sir.
Okay. If somebody does not understand the free radical, for them the simple idea is that most of the bacteria need iron for their growth. Okay. And in face of a bacterial infection, you don't give iron, supplemental iron therapy. It has been seen in several trials that iron therapy during an infection increases the risk of infection and mortality. So we don't give iron, we don't start iron till the infections are controlled. Like in this child also, we will start this child on antibiotics, presumptive antibiotics, and after 1 week, we presume that the infection is controlled, and then only we will start on iron therapy. It is not, somebody has written no iron absorption. That is not correct. Iron absorption occurs, but this may be harmful when given in acute infections. Yeah. Ashray.
Yes, sir.
So you will start F75. You should know the composition. What is F75? What is F100? When will you switch to F100? I think these are theoretical. I advise all of you to read the management carefully and give micronutrient. What all micronutrient you will give on day 1?
So on day 1, folic acid we give.
Okay.
Then we start on magnesium. Then we give zinc. We give
You give zinc, magnesium, folic acid. You
vitamin
also
D and potassium supplements, sir.
potassium supplement. And what else? Anything else? Vitamin A. What about vitamin A?
Yes, sir. Vitamin A, sir.
So you have to give a bolus. If the child is have xerophthalmia, then the dose is doubled. If the child is not having xerophthalmia, even then you have to give a bolus of vitamin A. Or nowadays, WHO even says that you keep on supplementing with 5,000 international unit daily, rather than giving a bolus of vitamin A. So that is another thing. I think so. Vitamin orally on day 1, folic acid 5 milligram on day 1, followed by 1 milligram every day. Magnesium sulfate, you can give 2 ml of 50% solution on day 1. And vitamin K, you have not mentioned. Vitamin K also needs to be given 2.5 milligram. And multivitamin supplementation is not, that MVI is not available in India, the the vitamin mix. So these are the things you need to you give. Ashray, you have any more questions for me?
Sir, if we are taking F75, then should we supplement with micronutrient, sir?
Yes, micronutrient, they need to be supplemented. That mix which contains copper and molybdenum and 2-3 more, that needs to be given, but unfortunately it is not available in India. So whatever we have, we just give any multi-micronutrient supplementation available in the market that contains most of the there are several which contains 15-20 micronutrients, small amount, so they need to be given. Another important thing is, and which you should remember, that traditionally it is taught that rickets does not occur in severe acute malnutrition, because rickets is a disease of growing bone, and in malnutrition, because the bone is not growing, so rickets will not manifest. But that is not true. We have seen that almost 40% of children with SAM do have some features of rickets, and approximately 26% suffer from hypocalcemia. So wherever you have features of rickets, it needs to be treated by vitamin D doses. Again, avoid a mega dose, give a dose on a daily basis, because it is a cumulative dosing management.
Okay, sir.
There's one more. Okay, potassium, I think we've already talked about. So I think that's we have discussed most of these issues about the management part. We can keep on discussing several times, but I'll prefer that all of you read through management. If there are some questions regard that you can always send on my email. Ashray will share my email ID with you all, and I'll reply. I usually respond within 24 hours. That is my maximum limit for responding. But
yes, even we got an immediate reply when we requested for.
And send on email, not on WhatsApp. WhatsApp, I am a little bit lazy, because there are 700 groups on my WhatsApp, so it is difficult to keep in track with them. Thank you, Ashray. Anything else or any other questions? I'll just wait for 2 minutes more if there are more questions there.
Sir, what about community management and facility management, sir?
Yeah, that's a very good question. I think one thing I like to point out, which we have not discussed at all, is that how to decide when a child of severe acute malnutrition needs to be hospitalized. See, previous notion was that all children with SAM need to be in hospital. Now there are over 7.58 lakh children with SAM in India, and how can you hospitalize all of them? So, and there are many children who are very well compensated at home, and they don't need hospitalization, and they may do well with community management. So the simple test that we all need to know to differentiate is known as the appetite test. In appetite test, simply this is a test to see whether the child is eating well or not. If the child is eating well, there is a method of the test. You can read in the textbook how much of food is given and in how much time the child should consume that food. If the child passes the appetite test, the result is pass or fail. So if the child passes the appetite test, that means the child can be managed in the community, provided that there is a caretaker who is able to take care of the child. That is also very important. The child appetite may be good, but the social circumstances may not be that good to allow management in community. So that's where again the child will have to be hospitalized. Community management is usually with the food. In Africa, you have to make a diet or you have to make a diet chart to give the mother and see that they are in a position to give that particular diet. You don't need very costly ingredients. They can be managed with simple food at home. In Africa, in war-ravaged situations, WHO and many other NGOs have used what is known as RUTF. RUTF, the full form is ready to use therapeutic food. But ready to use therapeutic food is very high energy dense food. And it is good for situations where there are no facilities for cooking food. Then this is the only alternative. But if you have, and it is not a long-term solution to keep the child in good health. It is only a very short-term solution. The idea is that the family should be counseled to make and supply good quality of food. Why malnutrition occurs in Indian children? It is not because the quantity given to them is less. They eat very well, but they will consume 1 kg of milk that will have only 100 or 200 ml milk. The rest all is water. Okay, they'll consume dal, but only dal water, but not the actual dal. So they don't, people are not knowing how the quality of the food or the complementary food has to be maintained. It is that which has to be improved and which can be done when you are doing the community-based management of severe acute malnutrition. There's a question, revise important finding to diagnose SAM. I think I have already said the diagnostic criteria are based on weight for height Z score, 1. Number 2, mid-upper arm circumference. 3rd, bilateral pitting pedal edema. And the 4th, gross visible severe wasting. These are the 4th criteria to diagnose SAM. Any one of them can diagnose SAM. Not all of them need not be present. Okay.
This is the advantage of learning from the authors. We have seen today, Ashray's presentation was looking everything perfectly normal and perfectly all right, but still the professor could correct so many things and he could change so many things. They are the authorities. These authors, they're the authorities in the subject and the field, so they can teach us the best possible. And it's a very privilege and blessings for us to learn from such renowned teachers, passionate teachers. It was a really next level, sir. Next level of learning for us today. A good experience for us, and we learned a lot from you today. Ashray, how did you feel?
Yes, sir. True, sir. I've learned a lot, sir. And thank you for accepting, sir. By just
that is a big thing for us.
Ashray, I must compliment you. You are wonderful. You will do wonders. At this first year of residency, I've never seen a child. You all are my children only. I've never seen a child present so well. Compliments and looking forward to more interaction.
You remember Dr. Anusha Hegde, sir? Your student last year, she completed the graduation.
Yeah, I remember.
From Bangalore.
Yeah,
She's
I know.
My batchmate there, and she used to take the classes for us in Vaitami, sir. She used to be the mentor, and then we thought, why can't we call the mentor of mentors, Piyush sir, and who is the author and authority himself. And
thank you, Krishna. Thank you.
Gladly you accepted, sir. As and when you are free, sir, we kindly request you to take some more classes for us, sir.
I'll be more than happy. Yeah, I'll be more than happy. Thank you, everybody. Thank you, Ashray. All the participants. I'm thankful.
Yes, sir. Thank you.
Stay blessed. Bye-bye.
Okay, sir.
Really well. Wonderful presentation, Ashray. And you are the best. Okay. We are not telling this. Professor himself has told. Okay. Very well done. Very well done.
It was all because of ma'am's help, Anusha ma'am's help.